Hello guys, welcome back to Dr. Arshid Nadeem Awan ultrasound and radiology teaching video. Hope you're all doing great and you're also benefiting community at large. Today I'm going to talk about the intracranial tumor, and that would be metastatic deposits. Many a time certain primary cancers leads to metastatic deposits towards the brain. So the primary deposits or primary lesions in the adults happens to be either the lungs or maybe breast or malignant melanoma. These all leads to metastasize to the liver, to the brain parenchyma. As far as the children tumors are concerned, the primary children tumors are happens to be neuroblastoma or Wilms tumor or osteosarcoma. These all metastasize to brain parenchyma. If you want to look on the radiological imaging, you will be able to appreciate multiple well-defined round lesion associated with vasogenic edema. If you're doing non-contrast imaging, on the non-contrast imaging, it would be maybe iso-intense to the brain parenchyma or slightly hypodense to the brain parenchyma. Isodense or hypodense on the CT images. And if you want to do the contrast, so on the contrast it will enhance with the IV contrast. But again, the one another point worth noting here that metastases are happens to be in many cases there will be either hemorrhagic metastatic deposits, or maybe cystic metastatic deposit, or maybe calcified metastatic deposit. So far the calcified metastatic deposits are concerned, it's usually seen in those tumors which producing mucin, like there will be GIT primary. It will cause the metastasis of the calcified nature, or breast. In even osteosarcoma, there will be calcified metastatic deposits. If there is hemorrhagic metastatic deposit, it would likely be due to melanoma or renal cancer, or maybe thyroid cancer or lung or breast cancer. It may lead to hemorrhagic metastatic deposits. The third tumor, when you may be able to see cystic metastatic deposits, this would likely be due to squamous cell carcinoma or adenocarcinoma of the lungs. So variety of metastatic deposits you can see, and on the basis of these presentation, you may look forward, or you may look to the or confirm the prime lesions as well. Metastatic deposits happens to be supratentorial in 80% of the cases, and these are all happens to be multiple in 70% of the cases. How we will appreciate these on the CT images, on MR images, and how we will distinguish it from one to another. So let's start watching these images. In the view, you can appreciate on the right side, this is a non-contrast CT axial image, while on the left side it is contrast enhanced CT axial image. You can appreciate that there is a well-defined enhancing lesion with calcification in it, and that is in the left temporal lobe. This is what the calcified mets will look like. This is metastatic deposits, and calcified metastatic deposit can be seen in mucin producing neoplasm, like they may be GIT tract, or they may be breast cancer, or they may be due to osteosarcoma. So these three can be the primary cause for the calcified metastasis in the brain. Another example for the calcific cerebral metastasis is here on axial CT image. You can appreciate a calcified metastatic deposit in the left-sided basal ganglia. So you can also appreciate that there is slightly compression on the lateral ventricle of the left side, and there is also slightly midline shift. This lesion is causing slightly midline shift. So this is what the calcified metastasis look on the CT images, and this could have been due to either GIT, primary GIT, or maybe breast, or maybe osteosarcoma. So you must be having some previous information while doing or while reporting these CT images. Another example of the calcified mets, here you can appreciate in the central line or cortical aspect of the frontal lobe, and then it also involves the occipital and temporal lobe, and you can also see the mets within the basal ganglia. So normally metastatic deposit happens to be multiple, and you must be provided with the previous information and medical record and history, which will show this mets maybe belongs to either GIT or breast or maybe osteosarcoma. I would comment on this CT image, CT axial image, as an metastatic deposits involving the right-sided basal ganglia, and it also involves the left side cerebellar region. So this is what the mets look on the CT images. Beside this, there is another point you can notice, that it shows hemorrhage. So this would be considered as an hemorrhagic metastatic deposits. Hemorrhagic metastasis deposits can be seen in melanoma, in the renal, and in the thyroid and lungs and breast. On this image you can also appreciate that the surrounding area shows hypodensity. It is showing infarct as well. So patient happens to be with a senile age or with the old age, with having the infarct associated with hemorrhagic metastatic deposits. Another example for the hemorrhagic metastatic deposits, you can see this is a contrast enhanced image, and multiple small hemorrhagic patchy areas. This is actually metastatic deposits seen on the axial images, that may be because of either thyroid or lungs or breast, or commonly melanoma and renal. These all causes hemorrhagic metastasis in the brain. Multiple hemorrhagic infarct can be seen in the periventricular area, in the basal ganglia, in the hippocampus, and in the frontal lobe and occipital lobe. So this is another example of the hemorrhagic metastatic deposits. Non-contrast axial image of the brain showing cystic metastatic deposits. On that you can appreciate there is a parenchymal edema. It's causing compression to the lateral ventricle, or it's also causing midline shift. So this is cystic metastasis, and this could have been due to squamous cell carcinoma of the lungs, or maybe adenocarcinoma of the lungs. Another non-contrast CT axial image for the cystic metastasis involving the frontal lobe, and it causing markedly midline shift, it compressing the ventricular system, and it also causing surrounding parenchymal edema. So metastatic deposit, especially cystic, it caused by the primary, maybe in the lungs, or originating from either the squamous cell or maybe adeno carcinoma of the lung, whatever the case may be, but this would be rising from the lungs and it's disseminate into the brain in a cystic way. Here is another CT axial image showing cystic metastasis involving the frontal lobe, with the perilesional edema. Surrounding edema is there, compression on the ventricle, anterior horn of the lateral ventricle is also compressed with minimal midline shift. So this is the primary was the lung cancer. You have seen all types of metastatic deposits on the axial images, including calcified metastasis. You have seen the way hemorrhagic mets will look on the CT images, and also you have noticed that how the cystic metastasis will appear on the CT images. So I have also discussed at length that primary may be in the adults, especially lungs and breast, and malignant melanoma causes cerebral metastasis, while in children there are multiple reasons ranging from neuroblastoma to Wilms tumor and osteosarcoma. So all these has been discussed at length, and I do hope this would be a worth watching video. At least you can memorize that which type of a tumor can metastatize to the cerebral region. With some new video, we'll see each other. Till then, take great care of yourself. Bye bye.